واضح? Can you see the presentation?
presentation واضحة والصوت واضح. Go ahead. بسم الله.
Okay, بسم الله. Assalamu alaikum wa rahmatullahi wa barakatuh. My name is Abdulrahman Nadrah. I'm a second-year abdominal radiology fellow from King Faisal Specialist Hospital and Research Center. Today, my topic is going to be about IgG4-related disease in the abdomen and pelvis. These are the outlines. I'm going to start off by going through the overview, followed by showing a couple of unknown cases. I will then put up a poll, and I would like you to participate by choosing a single best answer before going through each organ individually. First off, a brief overview. The pathological manifestation of IgG4 are tumefactive lesions with lymphoplasmacytic infiltrates, obliterative phlebitis, and storiform fibrosis. IgG4 typically manifest as space-occupying lesions that mimics malignancy. Timely diagnosis is crucial because IgG4 is treatable with steroids, and it is important that we avoid mismanagement with the invasive surgery. The disease is prevalent in middle-aged men with a slight predilection of males compared with females. The disease is often non-specific, and the high index of suspicion should be made, especially when multiple organs are involved. Follow-up after 2 weeks showing improvement after steroid therapy clinches the diagnosis. As Dr. Badr previously mentioned, in the past, IgG4 was thought to only involve the pancreas. However, during the early 2000s, Dr. Kamisawa suggested that IgG4 can include virtually every organ system in the body, not only the pancreas. My presentation will only focus on involvement in the abdomen and pelvis. Among the many organ disease involvement, autoimmune pancreatitis, IgG4 cholangitis, saladinitis, kidney involvement, and retroperitoneal fibrosis are considered among the most common. This is the first unknown case of a middle-aged male with obstructive jaundice. Please have a look at the images. I'll give you a few seconds before showing you the question. This is the question. I ask you, what is the most likely diagnosis? You can see the choices in front of you. Please choose what you think the best answer is.
I just want to let you know that no names will appear, so probably all of us should be attempting to give the answer. It's anonymous.
Okay, I'm going to end the poll shortly. Kindly please vote. Only 70% voted. Okay, so I'm ending the poll. The vast majority chose IgG4-related disease, almost 70%, and the 20% chose adenocarcinoma of the pancreas. I'll just show you the second case. This is the second unknown case. Once again, I'd like you to have a look before choosing the most appropriate answer, a few seconds before showing you the question. And this is the question. I ask you, what is the most likely diagnosis? Okay. Around 61% chose adenocarcinoma of the pancreas, while 22% chose IgG4, 10% chose MEN syndrome, and 7% chose lymphoma. I'll just go through the third unknown case. This is the case before last. Please have a look. And momentarily, I'm going to show you the question. This is the third question. I ask you, what's the most likely diagnosis? %77% chose IgG4-related disease, while 12% chose lymphoma, and 5% chose MEN syndrome, and none of the above. This is the last unknown case. Please have a look. I'll give you a few seconds before showing you the question. This is the question, and I ask you, what is the most likely diagnosis? %48% chose MEN syndrome, while 29% chose lymphoma, 21% IgG4, and around 2% chose adenocarcinoma of the pancreas. I'm going to move on with the presentation, and I'm going to start talking about the pancreas, since it's the most common manifestation of IgG4 in the abdomen and pelvis. Autoimmune pancreatitis are classified into type 1 and type 2, type 1 being the most common, prevalent in middle-aged men, commonly associated with elevated levels of IgG4 and has a favorable response to steroids, whereas type 2 is less common, affects a more younger age group, lacks the IgG4 elevation, and has a variable response to steroids. Autoimmune pancreatitis can be diffuse, focal, or multifocal. The focal or multifocal variant frequently mimics pancreatic malignancy. This is an example of diffuse autoimmune pancreatitis. You will notice the loss of pancreatic lobulations, the sausage-shaped pancreas, and the presence of peripheral rim-like capsule. Note the involvement of the pancreatic duct and the lower CBD. There will be long segment structure. This is the example of focal autoimmune pancreatitis. In this particular case, it's involving the tail. You will notice the focal loss of lobulation, the subtle peripheral rim-like halo capsule, which shows high T2 signal intensity, diffusion restriction, and delayed phase enhancement. The differential diagnosis for autoimmune pancreatitis is acute interstitial pancreatitis, and it can be distinguished by the presence of extensive fat stranding surrounding the pancreas, peripancreatic edema, pseudocysts, and necrotic collections in acute pancreatitis, while the presence of peripheral rim-like halo is pathognomonic for autoimmune pancreatitis. The second differential diagnosis of autoimmune pancreatitis is pancreatic adenocarcinoma, and there are multiple distinguishing features, including the famous duct penetrating sign, which is defined as segmental pancreatic duct narrowing through the involved diseased pancreas. The counterpart in adenocarcinoma is the abrupt cutoff sign. Note the presence of a pancreatic neck mass that's causing distal pancreatic atrophy and abrupt cutoff of the dilated pancreatic duct. Other distinguishing features between autoimmune pancreatitis and cancer is the presence of peripheral rim capsule in autoimmune pancreatitis, while in pancreatic malignancy, there will be usually vascular encasement, deformity, and abutment. Other distinguishing factors that favors autoimmune pancreatitis is the presence of multifocal biliary strictures rather than a solitary stricture present in adenocarcinoma. Enhancement duct sign is suggestive of inflammation, favoring autoimmune pancreatitis. The biliary stricture and the pancreatic duct stricture is usually long segment. And lastly, involvement of other organs in IgG4. While in pancreatic adenocarcinoma, we have spoken about the abrupt cutoff sign. There will be double duct sign, vascular encasement and deformity, in addition to metastasis. Moving on to the biliary tree, IgG4 in the biliary tree can manifest as IgG4 cholangitis and inflammatory pseudotumor. The affected segment show thickened wall, enhancement, luminal narrowing, and stenosis. Typically, the strictures involve a long segment. An isolated stricture of the lower CVD and pancreatic duct is common. The differential diagnosis for IgG4-related cholangitis is primary sclerosing cholangitis. There are multiple distinguishing features, including long segment stricture in IgG4 cholangitis, distal CVD narrowing, smooth and symmetrical thickening. While in primary sclerosing cholangitis, the strictures are band-like. We will have the beaded or prune tree appearance, irregularity diverticular, and asymmetrical thickening. Despite the presence of multiple distinguishing features, it is sometimes to distinguish between both entities. This is a table showing further differential diagnosis of IgG4 cholangitis, including AIDS cholangiopathy, recurrent pyogenic cholangitis, and choroidocholithiasis. This is a schematic showing IgG4 distribution in the biliary tree. Note the intrahepatic biliary involvement are usually long segment. Distal CVD and pancreatic duct is commonly involved as well. The other manifestation of IgG4 in the hepatobiliary tree are inflammatory pseudotumors. Classically, inflammatory pseudotumors have been subdivided into the fibrohistiocytic lymphoplasmacytic type. Is typically more associated with IgG4-related disease, and this is seen distributed equally in both sexes. It's equal in both hepatic lobes. Patients are usually symptomatic and the location is more central. This is an example of an inflammatory pseudotumor present in the right hepatic lobe. You will notice that the lesion is relatively well defined and shows low signal intensity on T1 weighted images and peripheral lobular post-contrast enhancement. The differential diagnosis of inflammatory pseudotumor in the liver is cholangiocarcinoma and metastasis. It's very difficult to distinguish between these entities on radiology alone, and in most cases, we rely on histopathological diagnosis. This came out to be IgG-related pseudotumor, inflammatory pseudotumor. Moving on to the kidneys are the most common organ affected in the retroperitoneum with IgG4. Disease involvement can be in the renal cortex, renal pelvis, sinus, and perirenal space. Among these, the most common involvement are seen in the renal cortex. Tubulointerstitial nephritis is the most common manifestation, followed by membranous glomerulonephritis. Renal cortical involvement of IgG4 can be multiple nodular lesions. As seen in this case, there are bilateral, multiple hypoenhancing soft tissue nodules that are relatively well-defined and uniform. These nodules are hypoenhancing and show corresponding dark T2 signal intensity on T2 weighted images owing to their hypercellular nature. Renal cortical lesions can have a diffuse patchy infiltration appearance. As seen in this case, there are bilateral renal cortical lesions extending all the way from the cortex into the medulla. Note, following steroid therapy, these lesions have completely resolved and multifocal renal scars have developed, which is typical for IgG4. Renal cortical lesions can be a single nodular lesion, rare, but it can happen. Note the left renal hypo-enhancing soft tissue nodule. It is solitary. It shows dark T2 signal intensity and diffusion restriction. This appearance really resembles papillary RCC. IgG4 in the kidney can involve the renal pelvis and renal sinus. Involvement can be unilateral or bilateral. This is an example of bilateral soft tissue thickening involving the renal pelvis and sinus. In some cases, renal parenchymal cortical lesions can coexist with renal pelvic lesions. As seen in this case, there is bilateral disease involvement. Note, after steroid therapy, all of these lesions have resolved. And finally, IgG4 in the kidney can involve the perirenal space by circumferential thickening. You can see the left kidney has perinephric space soft tissue thickening. There is also disease involvement in the left renal pelvic sinus. Note that the right kidney is atrophied. However, there is also right perinephric soft tissue thickening, and there is involvement in the renal pelvis. Just like in the pancreas and biliary tree, IgG4 renal manifestations are not specific and can resemble other entities, including renal lymphoma. In fact, IgG4 in the kidney can appear identical to renal lymphoma because renal lymphoma can also manifest as multiple nodular soft tissue lesions in the kidney. They can be solitary and they can involve the perirenal space. Here is an example of renal lymphoma. The right kidney shows multiple hypoenhancing soft tissue lesions. Note the bulky enlarged retroperitoneal lymph nodes. This resembles the infiltrative pattern of IgG4-related disease in the kidney. There is bilateral involvement, and the lesions are usually larger in lymphoma. The other differential diagnosis is pyelonephritis, as seen in the right kidney in this case. There are multiple peripheral wedge-shaped hypodensities, which are in keeping with pyelonephritis. The other differential diagnosis of IgG4 in the kidney are renal infarcts. Note in the left kidney, there are multiple peripheral wedge-shaped loss of enhancement compatible with infarcts. The right kidney, as you can see, is atrophied. IgG4 involvement of the perirenal sinus can resemble transitional cell carcinoma, as seen in this case. The right images is an example of lymphoma involving the perinephric space, which can look identical to IgG4. This is also lymphoma. Note the elongated soft tissue sheet mass along the root of the mesentery surrounding the vessels, in keeping with renal lymphoma. This is an example of Erdheim-Chester disease, which can resemble IgG4. Note the perinephric renal space involvement, anterior right perirenal thickening, and involvement of the renal pelvis. Moving on to the ureter, IgG4 in the ureter is very rare. Only few case reports are found in the literature. However, despite being very rare, there are few radiological patterns have been described, including polypoid mass-forming lesion. This is an example. You can note in the left distal ureter, there is a polypoid mass that's dark on T2 signal intensity and shows post-contrast enhancement. There is resultant proximal hydroureter. This case, actually, the presumptive diagnosis was IgG4 because this patient had elevated IgG4 serum levels, and surgical resection confirmed the diagnosis of IgG4 inflammatory pseudotumor in the left ureter. Other patterns in the ureter that have been described includes segmental ureteral wall thickening, which is seen in the top images. Note the segmental ureteral wall thickening that's causing proximal right-sided hydronephrosis. The presumptive diagnosis in this case was transitional cell carcinoma. However, upon surgical resection, the diagnosis of IgG4-related pseudotumor was made. The last pattern described in the literature is IgG4 periureteral fibrosis. As you can see in the lower image, the periureteral fibrosis resembles transitional cell carcinoma in the left ureter, and this was the presumptive diagnosis. Surgical resection allowed for the diagnosis of periureteral fibrosis. Moving on to the retroperitoneum, IgG4 can manifest as retroperitoneal fibrosis. Retroperitoneal fibrosis as a distinct entity is most of the time idiopathic, around more than 75% of the cases. It can be secondary to infections, malignancies, drugs, or other conditions. IgG4 is the cause of up to 2/3 of cases. The manifestation usually presents itself by periaortic soft tissue lesions that will cause a medialization of the ureters and proximal hydroureter nephrosis. Moving on to the prostate gland. Prostate gland involvement with IgG4 is very rare. There is minimal case reports seen in the literature. Despite being very rare, there are a couple of disease manifestations that have been reported, including diffuse organ enlargement, prostatitis, and loss of zonal anatomy, in addition to inflammatory pseudotumors. This is an example of diffuse prostatic enlargement, loss of zonal anatomy, and this particular patient had concomitant left renal pelvic sinus disease. The presumptive diagnosis was left transitional cell carcinoma and prostatitis. However, upon biopsy, this proved to be IgG4-related disease, and the patient dramatically improved following steroid therapy. The other manifestation of prostate gland in IgG4 are inflammatory pseudotumors. Note the bilateral symmetrical elongated soft tissue lesions that are avidly enhancing, taking up FDG, and this patient had bilateral pelvic renal sinus involvement. This patient had elevated IgG4 levels, and they suspected IgG4-related disease, which was the case, and this patient improved after steroid therapy. The urinary bladder is similarly rare. IgG4 involving the bladder is very rare. Only minimal cases are found in the literature. But again, there are a few radiological manifestations that can happen with IgG4, including transmural wall thickening, polypoid bladder masses, extraluminal perivesical masses. This is an example of polypoid bladder mass. Note the mass is tethering the adjacent sigmoid colon, and the presumptive differential diagnosis for this case was transitional cell carcinoma, tethering the adjacent sigmoid colon. And the other differential diagnosis was colon cancer invading into the urinary bladder. Upon surgical resection, this turned out to be IgG4-related disease, inflammatory pseudotumor. Once again, the disease manifestation in the testis are rare, very rare, but a few case reports in the literature prescribed paratesticular fibrous pseudotumors. They can manifest as orchitis and a solitary nodule. This is the only case that I found in the literature in regards to the uterus. IgG4 involving the uterus is very rare. This is a woman in her late 60s, and they found enlargement of the uterus. This patient also had ascites and pleural effusions, multiple retroperitoneal lymph nodes that these images are not shown. Upon surgical resection, this turned out to be IgG4-related disease involving the ureter, lymph nodes, and retroperitoneum. Similarly, IgG4 in the ovary is very rare. This is a woman, almost 60 years old, having a left adnexal mass. You can note that the mass is isointense on T1, hyperintense on T2, severely restriction diffusion. The case report described multiple pelvic lymph nodes, retroperitoneal lymph nodes, and the presumptive diagnosis was primary ovarian malignancy. Upon surgical resection, this turned out to be IgG4-related disease. The cervix is also very rare in regards for IgG4. I found this case also in the literature. This case is a bit interesting. This is a female who's known to have primary cervical cancer with parametrial invasion. However, this patient also had multiple pelvic retroperitoneal lymph nodes, multiple lesions in the pancreas, liver, kidneys, and multiple lesions in her salivary glands. Initially, they thought that these are related to cervical cancer metastasis, but it was not very typical, so they biopsied one of the lymph nodes, and this turned out to be coexisting cervical cancer, along with IgG4-related disease in the retroperitoneum, pancreas, liver, and salivary glands. This is a very interesting case. Before I conclude, I just want to go through the unknown cases. So this patient, the MRCP showed distal CVD stricture, apparent irregularity in the intrahepatic ducts. The patient also had an ill-defined lesion in the pancreatic head. The distal pancreas appeared unremarkable. The lesion, as you can see, was hyperintense on T2-weighted images. The CT, the lesion is hypo-enhancing. Distal pancreas appeared unremarkable. Note the presence of multifocal bilateral renal cortical lesions. The reporting radiologist suspected that this is actually IgG4-related disease, and it was called as such. However, this turned out to be pancreatic adenocarcinoma, and the lesions in the kidney turned out to be regular nephritis. I brought this case just to show you how challenging it could be differentiating between both entities. It's always wise to correlate with tumor markers, IgG4 levels, and it's also becoming common practice that once IgG4 is suspected, follow-up after steroids should show disease regression. Otherwise, you need biopsy. The second case, the majority chose pancreatic cancer. This turned out to be focal disease involvement in the pancreatic head of IgG4-related disease. This is an example of focal autoimmune pancreatitis in the pancreatic head. I agree that this appears suspicious for cancer because of the apparent duct cutoff sign, which is associated with malignancy rather than autoimmune pancreatitis, and there is relative distal pancreatic atrophy. However, this patient showed dramatic improvement after steroid therapy, and the pancreas returned to looking normal. The majority of you got this case right. This is an example of autoimmune pancreatitis of the pancreas. Note the loss of lobulation, sausage-shaped pancreas, and the subtle peripheral rim-like capsule. There is also IgG4 disease involvement in the left kidney. Apologies if the images is not clear. I tried to do my best in making it clear. Also, there is disease involvement in the biliary tree. Note the symmetrical thickening of the extrahepatic ducts and the intrahepatic duct involvement. So this turned out to be autoimmune pancreatitis and IgG4 cholangitis, in addition to disease involvement in the left kidney. This is an interesting case. I believe the majority chose Men's syndrome. So this patient had a mass in the porta hepatis. There is secondary intrahepatic biliary dilatation, and there is this lesion here in the left thyroid and the left thyroid gland. The presumptive differential diagnosis for this case was IgG4 and lymphoma. Tissue diagnosis proved that this turned out to be a case of lymphoma. So in conclusion, IgG4 affects almost every organ and often has non-specific features, mimicking malignancy and inflammation. Simultaneous organ involvement should raise suspicion of IgG4 and should prompt treatment with steroids. Improvement after steroid therapy makes the diagnosis highly likely. Correlation with IgG4 levels is useful, but it is as important, if not even more essential, to correlate with tumor markers. Equivocal cases will require histopathological diagnosis. Before I conclude, I would just like to thank Dr. Badr Mtlairi for giving me the opportunity to present IgG4-related disease. I would also like to thank Dr. Fawaz Al-Harbi. The unknown cases was provided by him. I would like to thank Dr. Hana Al-Falih because she also provided one of the unknown cases and helped me with this presentation. While I was presenting this presentation, I reached out to Dr. Hassan Al-Zahrani. He published a few papers in relation to the topic, and he was very helpful. He provided me with reading materials. I would like to thank him and all of you. And thank you so much for listening to me.
يعطيك العافية Abdulrahman. Excellent presentation. And you highlight the importance of this topic, and it's very great mimickers for many diseases. and we have to put it in the proper context in our differential diagnosis, especially in difficult cases and some cases that is not typical or the biopsy was not conclusive. Sometimes it's very helpful to include IgG4-related disease in your differential diagnosis. We have Dr. Mut'ab will share the screen with a new recent paper trying to differentiate between adenocarcinoma and IgG4 utilizing texture analysis. So Dr. Mut'ab.
Thank you, Dr. Badr. I wouldn't take so much long time. Just quick note about this is very recent study from Baltimore, from Johns Hopkins Hospital. And it's going to study about the radiomic features, or what we call texture analysis. And in that study, they have reached very high sensitivity in discriminating IgG of pancreatitis versus adenocarcinoma with 100% specificity. And they have collected all these features to differentiate the tumor from IgG. And out of all these features, which are on hundreds, they found the most related three important features are cluster shade, variance, and kurtosis. We're going to have a dedicated workshop near future, inshallah, for our fellows, how to estimate those parameters as a workshop. And it's not going to be limited for pancreatitis. You could utilize it for other organs like prostate, liver, or whatever things come into your mind. Thank you.
Dr. Mut'ab. So for the